Okay, now continuing off of part 1 of this lecture series, this is part 2 of the Acute Treatment and Rehabilitation of Skeletal Muscle Injury lecture series. And as a brief overview of part 1, let's outline what we know so far in terms of post-muscle strain care and rehabilitation. First, as I emphasized in part 1, the primary focus and really the only focus of strain management, starting from the acute treatment phase or phase 1, is to maximize late functional recovery. Remember, late functional recovery is the full restoration of muscle function, both in isolation and as part of the whole body system, especially in sport-specific movements when we're dealing with athletes. So how is late functional recovery optimized, at least fundamentally speaking? It is achieved by facilitation of quality healing, which was defined as a greater muscle regeneration to scar tissue formation ratio. We want both structural and functional healing via regeneration of muscle versus just structural and non-functional healing via connective scar tissue formation. In simpler terms, we want to facilitate muscle regeneration and prevent fibrosis, which is excessive scar tissue formation. So to probe this further, let's ask the question of how. How do we promote quality healing as defined just earlier? How do we improve the regeneration to scar tissue formation ratio? How do we facilitate more regenerative healing versus fibrogenic healing? Two major factors. First, we need to address the wound gap, just like when we cut our skin. To reiterate, the larger the wound gap, the greater need for scar tissue to provide immediate structural support and thus a greater risk for fibrosis. This means a lot more regeneration would need to occur to condense the scar tissue in the middle and to interlace the fiber stumps. We want to implement interventions immediately to minimize excessive expansion of the wound gap in the muscle. This again is the gap between the surviving zone fiber stumps. In between, we have the central and regeneration zones. So in order to minimize the gap between surviving zones, we need to minimize the expansion of the central and regeneration zones. The price or police principle describes the immediate acute treatment strategy to support this process. So again, the question of how. How do we minimize excessive expansion of the wound gap to help promote quality healing? First, we want to control excessive inflammation, especially with severe grade 2 to 3 strains. This would help reduce unnecessary levels of degradation and necrosis of undamaged fiber segments within the surviving zones. Basically, we want to prevent the expansion of the regeneration zones into its adjacent surviving zones. Second, we want to control edema and hematoma, which fills the central zone. Most of the modalities outlined in the price principle or police principle address this issue. By controlling the swelling and bleeding, we can help reduce the wound gap by reducing the central zone, or at least preventing the expansion of the central zone. Okay, so how else can you improve quality of healing to facilitate late functional recovery? Next, we have improving early functional recovery to facilitate early mobilization and thus optimal and progressive loading of the injured muscle. In part 1, we discussed the evidence concerning early mobilization and its effects on late functional recovery compared to early immobilization and delayed mobilization. We saw that the late functional recovery rate is much faster with early mobilization. And this is aided largely through optimal and progressive loading, which provides appropriate amounts of mechanical stress to the muscle to stimulate regenerative and growth processes in muscle. So again, how do we achieve early functional recovery and thus mobilization? Well, we have to think of the three major limiters of muscle function during the acute post-injury phase. We have ultrastructural damage to the muscle fibers, which prevents cross-bridge formation and thus contractions. We have motor neuron denervation, which impairs neural activation of muscle fibers, which is necessary for contractions. And of course, we have sensory feedback in the form of pain via nociception. And as I emphasized a number of times in part 1, of these three factors, the only one that is modifiable during the acute treatment phase is pain. So pain management, more so careful and controlled pain management via analgesic modalities, can facilitate early functional recovery / mobilization by reducing hyperalgesia, or in more common terms, tenderness. So why is early functional recovery / mobilization, and thus optimal loading, critical for facilitating late functional recovery? It is because it provides a mechanical stimulus for regeneration as well as anabolism, particularly muscle protein synthesis. Remember, it's not just about reconstructing damaged fiber segments, but also growing those fiber segments through anabolism, particularly the synthesis of proteins involved in the structure and function / contraction of muscle fibers. These are called your myofibrillar proteins. We'll discuss this further in this lecture series. So with that said, we discussed in some detail the mechanisms underlying common analgesic modalities, again for the sake of improving early mobilization to allow for optimal and progressive loading throughout your treatment and rehabilitation. First, we must understand that hyperalgesia following an injury is biologically purposeful. It's not there just to make your life miserable. It is there as sensory feedback to protect the injured organ or tissue, in this case the muscle. So proper pain management is not totally eradicating the pain, but just managing it so it's enough for you to mobilize the muscle. Obviously, if pain was completely removed from the situation, you would likely return to sports since there is no pain. Of course, function would still be limited due to other limiting factors, but the main point would be that the primary protective mechanism is removed, and thus the muscle is at risk for re-injury due to premature mechanical stress to the vulnerable muscle. This would of course impair the proper healing and repair of the muscle. This is the fundamental basis for controversies related to potent analgesic drugs that are often effective in totally diminishing pain. So it's about controlled and careful pain management and still allowing the body to utilize this sensory feedback to inform you as you progress through treatment and rehab. So the biological targets for analgesic modalities are upstream of the CNS. The only one I discussed that targets the nociception pathway at the CNS are opioids, which block communication between the nociceptor and the spinal neurons that project that pain signal to the brain. The two general categories of analgesic mechanisms include 1. Disruption of nociceptive signals, which involve the gate control theory and thermal stimulation of TRP receptors, and 2. Mitigation of noxious stimuli, which largely involve inflammatory chemicals like prostaglandins. This largely involves inhibition of the cyclooxygenase pathway, which forms these prostaglandins. Now, always keep in mind that certain prostaglandins, like the ones listed here, are not only noxious stimuli that causes hyperalgesia, but they are also critical signaling molecules for regeneration. This is why inhibitors of the cyclooxygenase pathway like NSAIDs and corticosteroids are controversial in sports medicine. Evidence of this was provided through the rodent studies I presented using a cyclooxygenase knockout model, where cyclooxygenase deficiency resulted in poor healing quality following muscle injury. And this was characterized by more fibrogenic scar tissue formation versus regeneration. And this provides insight as to what may occur with cyclooxygenase inhibition through high-dose, long-duration NSAID use. Of the possible analgesic modalities, I mentioned that icing or cryotherapy may be the most practical, at least within the acute treatment phase. This is because icing is arguably the most versatile. It elicits analgesia through thermal stimulation of TRP receptors on those nociceptors. Again, this is not related to the gate control theory, nor is its analgesic effects mediated through anti-inflammation. Icing exerts a very minor anti-inflammatory effect, which may not contribute to analgesia, but possibly contribute to the minimization of excessive degradation and necrosis, especially with severe grade strains. And also, adding to its versatility as an acute treatment modality, it has shown to reduce edema and hematoma around the strain, helping the athlete minimize excessive expansion of the wound gap. Also to add, as presented in the research studies I linked in the last lecture, icing, at least during muscle strain situations, do not appear to negatively impact regeneration, unlike high-dose NSAID use. This is likely due to the fact that icing does not directly mitigate or impact specific chemicals or signaling molecules that are critical to the stimulation of regenerative processes, For example, it does not appear to inhibit cyclooxygenases or phospholipases and reduce the formation of prostaglandins. And just to reiterate, since this is the critical factor leading into this lecture series, controlled pain management during the acute treatment phase is fundamentally implemented to promote early functional recovery/mobilization to allow for optimal and eventually progressive loading through exercise therapies. Again, exercise is regenerative medicine, and this is evidence-based, as I presented in part 1. So what's next? Obviously, we have to discuss the next phases of post-strain management leading up to full late functional recovery and thus to a return to sport status. This includes the following phases from 2 to 5. Post-acute management, functional rehab and general athletic reconditioning, reconditioning specific to the metabolic demands of the sport in addition to strength retraining, and lastly, return to sport, which is when muscle function in isolation and in whole body sport-specific movements are fully recuperated. As for some added topics to finish off this lecture series, I will discuss some alternative therapies, mainly blood flow restriction therapy, as well as some topics related to prehab, with a focus on strength trainings, especially eccentric overload training. Then here we have an outline of our next lecture series after this one, but I'll have you quickly review that so that we can stay on topic as we move forward. So first, let's start off with the basics. We know overall we are trying to optimize the rate of functional recovery. Now, when we say function, we are essentially referring to the variable of strength, which is the capacity by which force is produced through muscle contractions within a given joint action against a given level of resistance. So function and strength are interchangeable because they are referring to the same thing in the context of muscle. So functional recovery is fundamentally the recovery of strength. Now, I would like you to keep in mind that muscular strength or muscular function can be more accurately described as neuromuscular strength or neuromuscular function, respectively. And this is because strength is not only determined by factors within just the muscular system, but also the nervous system as well. As we all should know by now, the force-generating capacity of any given muscle is not just about the physical characteristics of the muscle itself, but also determined by the manner in which the nervous system activates the muscle for contraction. So in other words, as outlined here, the underlying components of neuromuscular function/strength include neural activation of muscle and muscle size and mass. For the neural component, we are referring to the motor nerve system, aka the somatic nervous system. These include motor neurons, which are the opposite of sensory neurons as they transmit motor signals from the CNS to the muscle, leading to contraction. And this is an efferent signal as opposed to an afferent signal. So the manner in which the CNS through the motor nerve system activates the muscle partly determines the strength or function of the muscle. For the muscular component, we have muscle size and mass, which is determined by the size and mass of the individual muscle fibers of that muscle. Now, as you can see, there is a red asterisk here, and the description is down below. It must be clarified that it is not the size and mass of the muscle nor the muscle fiber that contributes to strength directly, but rather what's inside the individual muscle fibers. Let me explain in detail. The size and mass of a whole muscle, like your biceps for example, is determined by the collective size and mass of all the individual muscle cells or fibers that make up the biceps. So do you think the size and mass of individual fibers is the direct factor that contributes to the strength of the biceps? No, rather it is the change in the amount of certain content within the individual muscle fibers that directly contribute to the strength of the muscle fiber and thus the muscle. So what is this content that I am referring to? What is this molecule within the muscle that I am referring to? I am referring to a categorization of proteins called myofibrillar proteins. Now, if you remember the term myofibrillar, you would know it is describing the myofibrils, which is a component of the muscle fiber that contains all the proteins involved in muscle contractions, all packaged into organized units called the sarcomeres. These include proteins such as the well-known actin, tropomyosin, and troponin of the thin myofilament, and the myosin of the thick filament. In addition, structural proteins like proteins of the Z and M lines are also myofibrillar proteins. All these myofibrillar proteins are necessary for contraction and thus force production. So imagine within each muscle fiber that makes up the biceps, there was an increase in the construction or synthesis of these myofibrillar proteins and thus myofibrils. How do you think this would affect the strength of the muscle fiber during a contraction? Would it produce more force per contraction or less? It would without a doubt produce more force. Now imagine all the muscle fibers within the biceps underwent an increase in myofibrillar protein synthesis. This means each muscle fiber will become stronger per contraction, and thus at the tissue level, the biceps will be stronger per contraction. It will have a greater force-producing capacity. So as you can see, the direct contributor to strength in terms of the muscular component of neuromuscular strength is the myofibrillar protein content within each of the individual muscle fibers. Thus, with an increase in myofibrillar protein content, the muscle fibers and thus muscle becomes stronger. And it will be the vice versa effect with a decrease in myofibrillar protein content. So where does muscle fiber and thus muscle size and mass come into play here? Well, as I said, the change in the size and mass of the muscle and muscle fibers is not the direct contributor to strength, but rather a manifestation or a side effect, if you will, of the change in the myofibrillar protein content in each of those individual muscle fibers. So when there is increased synthesis of myofibrillar proteins within a given muscle fiber, more stuff, for a lack of a better word, is being constructed within the cell. In other words, within each muscle cell or fiber, there will be more matter taking up space. And thus, the muscle fiber will expand, increasing in size as well as mass. This is the same principle as filling a balloon with water molecules. As a balloon fills with water, there is more matter being put into the balloon, and thus the balloon increases in size and mass. In this case, the muscle fiber/cell is the balloon, and the myofibrillar protein molecules is represented by the water molecules in this water balloon analogy. So when we say that muscle hypertrophy in response to resistance training contributes to strength development, it is rather the process that underpins the muscle hypertrophy that is the direct contributor to strength development. And again, that is an increase in the synthesis and accretion of myofibrillar proteins within each of the muscle fibers. So in summary, the two components of neuromuscular strength development includes an increase in neural activation of muscle and the synthesis and accretion of myofibrillar proteins, resulting in an increase in muscle size and mass, aka muscle hypertrophy. These represent the neural and muscular components of neuromuscular strength/function, respectively. Now, what happens when neural activation of the muscle decreases and myofibrillar protein degradation increases, reducing myofiber size and mass, aka muscle atrophy? It goes without saying that neuromuscular strength and thus function would decrease. Now, when you look at this carefully, you would notice that the focus of strength training or resistance training is to enhance neuromuscular strength and function through the enhancement of neural activation of muscle and muscle hypertrophy via increased myofibrillar protein synthesis. So in essence, the focus of muscle rehabilitation following a strain or injury is exactly the same as resistance training. The only difference is that muscle rehabilitation is the restoration of neuromuscular function/strength, and thus the restoration of neural activation of muscle and restoration of muscle size and mass, and thus myofibrillar protein content. So with post-injury muscle rehabilitation, we're not necessarily trying to enhance these factors to enhance neuromuscular strength, but rather to restore these factors to restore neuromuscular strength. That is the distinction between rehab and strength training. But fundamentally, both target the same physiological factors that underpin strength development, and thus, muscle rehabilitation is at its core strength training or resistance training. It is, however, modified or adapted strength training, which is strength training modified for or adapted to an injured muscle. So first, let's describe the impact of the strain on the neural and muscular components of neuromuscular strength/function. As you can see in this table, we have broken it down to the direct and indirect impact of the muscle strain on the neural and muscular components of strength/function. So starting with the neural component of muscle function, the direct impact of injury is motor neuron denervation, which we discussed in the prior two lectures. Denervation occurs when the neuromuscular junction is damaged along with the muscle fibers. Just as a reminder, the neuromuscular junction is simply the connection between the motor neuron and the muscle fiber, and is the area of neurotransmission between the neuron and the fibers. Therefore, this would sever the communication between the motor neuron and muscle fibers, and thus impair the activation of the muscle fiber, which would of course in turn impair contractile function and strength of the muscle. Another way the motor neuron is denervated is through the damage to the nerve fiber itself. This often occurs, as I mentioned, when the axon of the motor neuron is located at the site of the rupture. Now, what about the indirect impact of injury on the neural component of neuromuscular strength? As you can see, this is related to the disuse or deloading of the muscle while it is injured. In other words, the indirect effects of injury on muscle function/strength are related not to the injury directly per se, but rather the inability to utilize and load the muscle as you did prior to the injury. And of course, we should all know what occurs when you stop using your muscles and when the muscle is void of any stress via loading. We know that it gets weaker, strength decreases. This is called deadaptation. So the neural factor contributing to this disuse or deload-mediated loss of strength is a decrease in the capacity by which the nervous system activates the muscle. We can describe this as a decrease in neural drive and thus motor unit activation. If you don't remember what a motor unit is, it would be beneficial for you to review this term. A motor unit is a single motor neuron and all the muscle fibers it innervates. In a given muscle, like say the rectus femoris for example, there will be multiple motor units. Some muscles have larger number of motor units than others. On the next slide, I will have a visual of motor units. When muscles are activated by the nervous system to contract, the CNS determines how many motor neurons and thus motor units will be activated. This will determine the number of muscle fibers that contract and thus the amount of force the muscle will generate. This describes a neural drive. When there is disuse or deload of the muscle, in other words, the muscle is no longer exposed to mechanical stress, the CNS reduces the amount of neural drive towards the muscle, and thus during contraction, there are less motor units and therefore less muscle fibers contributing. As a result, less force is generated. We will get more into detail on this decrease in neural drive in the next slide. So now what about the muscular component of strength? What is the direct impact of injury on the muscular component of strength? We know up to this point that neuromuscular strength is directly and negatively impacted by the injury through motor neuron denervation. But what else? As we should all be familiar with by now, a muscle strain is characterized by the rupture and therefore damage of multiple muscle fibers. So at the rupture site, the individual components within the muscle fiber that are responsible for contraction are damaged. This includes the components of the sarcomeres. We are talking about destruction and disarrangement of structures like the thick and thin myofilaments. Remember, when the muscle contracts, the thick and thin myofilaments physically interact with one another to form a cross bridge. And through the process of cross bridge cycling, the sarcomeres and thus muscle fibers can produce tension. So without the proper sarcomere arrangements, this cannot occur. In addition, we also know by now that following the injury, there is an elevated level of protein degradation and necrosis, which would also impair the contractile ability of the muscle fibers and thus muscle. Now, what about the indirect impact of injury on the muscular component of strength? Just like the neural component, this is simply a result of disuse and deloading of the muscle. As we all know, when you remove any load-mediated stress to the muscle, over time, the muscle will atrophy. And as I mentioned, the atrophy or hypertrophy of the muscle and its muscle fibers is largely mediated by protein metabolism within each muscle fiber. When there is an increase in protein synthesis, like when the muscle is loaded consistently over time, such as with resistance training, there is more quote unquote stuff being built inside the muscle fiber, and thus taking up space within the muscle fiber, and thus the muscle fibers hypertrophy. They increase in size and mass. But when the muscle is deloaded or disused, the muscle proteins, specifically the myofibrillar proteins, degrade. This will result in less quote-unquote stuff inside the muscle fibers and taking up space within the muscle fiber, and thus the muscle fibers would atrophy. So it is not the atrophy per se that contributes to strength declines with deloading, but rather the lower myofibrillar protein content. So now when the injured muscle is deloaded and there's greater myofibrillar protein degradation and thus less myofibrillar protein content over time, this means there are less myofibrillar proteins available to contribute to muscle contractions. This would in turn reduce the force-producing capacity of muscle fibers and thus the whole muscle. Okay, so now that we know the direct and indirect impact of a muscle strain on neuromuscular strength components, we are now aware of the factors that need to be reversed and restored. We need to re-innervate motor neurons and regenerate and remodel the damaged muscle fibers and its contractile elements. This is all resolved through the normal biological processes of healing, more specifically, regenerative healing. So one of the major aspects of acute treatment and rehabilitation is to implement strategies to facilitate regenerative healing. And over many years of research, exercise has been arguably the most effective modality. This is the foundation of physical therapy. Of course, there are other regenerative therapies. For example, I went over some details regarding some prolotherapies like PRP. But as the research showed, exercise therapies are the most effective in facilitating regenerative healing and the remodeling of the damaged muscle segments. I hinted earlier as to why that is the case, and as a reminder, it is due to the stimulatory effects of loading and that tension-derived stress from exercise on muscle regeneration, and this will be a focus within this lecture. As for the indirect impact of injury on neuromuscular strength, well, this is resolved in the same manner general non-injury related weakness is resolved. It is simply through exercise training, more specifically resistance training. Now, in the case of rehabilitation following a muscle injury, it would first be exercise therapies before exercise training. Fundamentally, they provide the same stimulus to increase neural drive and increase myofibrillar protein synthesis. Therapy is just simply training adapted to an injury situation. Now, as you can see, the common theme here is exercise. Exercise is the primary evidence-based means to restoring neuromuscular function and strength following an injury. Exercise reverses the negative direct and indirect impact of injury on both neural and muscular components of neuromuscular function/strength. Now, just to get even more specific here, it is not exercise per se, but rather the loading of the neuromuscular system through exercise that resolves these negative effects of injury. So loading is the factor and is the basis for rehabilitative strategies for muscle strains. So naturally, the question is why? Why is loading, more so overloading, and thus tension-induced stress to the muscle, a significant component of rehabilitation and functional recovery? First, let's examine the effects of loading on the neural component of strength. In other words, let's examine the neural adaptations to frequent loading that contributes to a restoration of strength and function. First, we need to discuss the three factors that determine how the CNS and the motor nerve system influences strength. Each of these factors collectively underpin neural drive, which is a term I introduced earlier. Now, regardless of the muscle's size and mass and the myofibrillar protein content within said muscles, strength is determined largely by the manner in which the CNS and the motor nerve system activates it. So you could have big muscles, but be relatively weak if your nervous system has poor neural drive to the muscle. All right, so let's look at the three neural factors that characterize neural drive and represent the neural component of strength. So first, I must reiterate the definition of a motor unit. It is a single motor neuron and all the fibers it innervates or connects to. So in this particular example here, this is one motor unit. There's one single motor neuron innervating 3 muscle fibers. This is a motor unit. Some motor units are larger than others, meaning some motor units have one single motor neuron with many muscle fibers that it connects to, and some motor units have one motor neuron with a small number of muscle fibers it innervates. So in this example, we'll just use motor units that comprise of one motor neuron and 3 muscle fibers. Now, as I mentioned before, every muscle in your body has multiple motor units. The collection of motor units within a muscle is referred to as the motor unit pool. Some muscles have larger pools than others. Now, when your CNS activates a single motor neuron like this one in this example here, and action potentials are transmitted in the efferent direction from the CNS towards the muscle fibers that this motor neuron innervates, so these 3 fibers here, will contract, and it will contract with as much force as it possibly can, meaning when this motor neuron activates, these muscle fibers will contract as hard as possible. This is described by the all or none principle, which states that when a single motor neuron fires, all the associated muscle fibers will contract maximally. So with that being said, the total amount of force that the muscle produces during a given joint action and resistance is largely determined by how many motor neurons and therefore how many motor units are activated. This will in turn determine how many muscle fibers are maximally contracting for that given joint action and resistance. The amount of motor units activated by the CNS for a given joint action against a given resistance is referred to as motor unit recruitment. As you can see by this figure, we have a very simplified visual of motor unit recruitment. Let's use an example of a bicep curl against a 20-pound dumbbell weight. Prior to injury, 3 motor units within the biceps were recruited to curl that 20-pound weight. Again, these numbers are just for the sake of a simplified example. Now, say you strained your biceps, and because of the injury, you are not able to use and load the biceps the same way you did prior to the injury. So as a result, there was disuse and deload-mediated reduction in strength. On the neural component, there was a decrease in neural drive as a deadaptation to this disuse and deloading. One major factor contributing to this decreased neural drive is the reduced recruitment of motor units during the bicep curl against that 20-pound weight. So to relate this to this figure, after the injury and the ensuing disuse and deloading, the CNS is now only able to recruit 1 motor unit for the bicep curl against that 20-pound weight. And as a result, you are either unable to produce enough force to curl that weight, or the weight is curled a lot slower than before the injury. And just to note, as we move along, the reduction in strength as demonstrated in this bicep curl example against this 20-pound weight manifests in simply slower velocity joint actions against a given resistance. Just like the 20-pound curl example, when your biceps become weaker, that 20-pound curl looks a lot slower. And again, to relate this to the current topic, part of this is due to a decrease in motor unit recruitment during that 20-pound bicep curl. Okay, so just using basic logic here, if we wanted to restore strength back to pre-injury levels, what would need to occur with motor unit recruitment? We would need to go back towards the right in relation to this figure. And once again, this is all mediated by the central nervous system, the CNS. The nervous system, particularly the motor nerve system, is highly adaptive to stress or demands. So when you progressively load the muscle, like during rehabilitation, the CNS and the motor nerve system begins to adapt, largely by improving motor unit recruitment. The CNS, in a sense, relearns how to activate the muscle. It relearns how to recruit motor units. And the way to teach it is to provide some type of stress or demand. And that specific stress or demand is loading, resisted contractions, tension, etc. So up to this point, we know that a decrease in neural drive in response to injury is largely due to a decrease in motor unit recruitment for a given joint action and resistance, just like that bicep curl with the 20-pound dumbbell example. Through rehab and proper loading of the muscle, motor unit recruitment improves as an adaptation to the consistent stress imposed by the loading. Okay, so what other neural factors related to neural drive are negatively affected by injury and deloading and are adaptable to rehabilitation and loading? Next, we have motor unit firing rate, aka frequency. Now, I'm not going to go into fine detail regarding these mechanisms because it would be too redundant to my advanced exercise physiology course, so I will explain in more general terms here. Motor unit frequency is the rate of action potentials transmitted by the motor neuron from the CNS to the muscle. So action potentials per second, in other words. The amount of force produced by each of the fibers innervated by the single motor neuron is largely determined by the rate of action potential it receives. Simply put, the greater the frequency of action potentials, the greater the force generation, and vice versa. So as a result of injury and the ensuing disuse and deload, the frequency by which the CNS transmits action potentials through the motor neurons towards the innervated muscle fibers are reduced. This is again a de-adaptation to deloading. And we can see that in this figure. These lightning bolts represents action potentials. So the figure showing more action potentials here represents higher frequency of action potentials. This represents a lower frequency of action potentials. So as a result of injury and disuse and deloading, we have a shift from the right to the left, resulting in decreased neural drive and decreased neuromuscular strength. So as the muscle is reloaded through rehabilitation, the CNS again relearns how to activate the motor units. One way is through increased motor unit recruitment, and another is through increased frequency or firing rate of action potentials for each of the recruited motor neurons/units. So you see a shift from the left back to the right. Next, we have motor unit synchronization. Muscular force production and strength is also influenced by the ability for the recruited motor units to be activated synchronously so that the muscle fibers all contract in a more synchronous fashion. With greater synchronization of motor unit activation, there is greater accumulation of force across the recruited motor units. Let's look at this figure here. Prior to injury, let's say 3 motor units recruited to curl a 20-pound weight are activated synchronously, and you can see that by the action potentials flashing in a more synchronous fashion here. Remember, within each individual motor unit, the fibers contract maximally when activated. So in this example, this group of 3 fibers, and this group of 3 fibers, and this group of 3 fibers all contract maximally and synchronously. Therefore, the forces produced by each of these motor units accumulate, and the overall net force production is maximized when the activation is synchronous. Now, as a result of injury and disuse and deloading, motor unit synchronization has shown to be negatively affected. As you can see in this figure to the left, the action potentials and thus activation of the motor units are asynchronous. This means that this group of 3 fibers, this group of 3 fibers, and this group of 3 fibers are contracting maximally at different rates and times, and therefore the net overall force production from these 3 motor units is reduced because force production does not accumulate since they are all firing at different times. You can think of this as you lifting something heavy with 2 of your buddies. When we do this, do we all just lift at random times? No. Why? Because the overall force produced by the 3 of you would not be maximized. It would not accumulate, in other words. So what do you do almost naturally in this scenario? You would lift on the count of 3. 3, 2, 1, lift. You and your buddies then lift synchronously, and the item can be lifted more efficiently. Why? Because there is an accumulation of force from each of you and thus greater net force production. So to reverse this loss of motor unit synchronization, you need to add some stimulus for synchronization to be restored. And again, the stimulus is afforded through loading. Okay, so in summary, we have a decrease in neural drive in response to injury, disuse, and deloading, and an increase in neural drive in response to rehabilitation/training and loading. The three factors that constitute neural drive are motor unit recruitment, firing rate/frequency, and motor unit synchronization. Now, keep in mind, as a result of the injury, we said that the direct impact can be motor neuron denervation. So just imagine these motor neurons being severed or these neuromuscular junctions being destroyed. So obviously in that case, motor unit recruitment, motor unit frequency, and synchronization would be impaired as a direct impact of the injury. And like I said, that will be resolved through natural processes related to regenerative healing. So this figure, in essence, is representing more so the indirect impact of injury as described in the last slide, and the restoration of neural drive through rehabilitation and loading. All right, now let's examine the muscular component of neuromuscular strength/function, and again ask the question of why loading is a significant component of rehabilitation and functional recovery. In other words, why and how does loading through exercise therapies stimulate processes within muscle critical for regeneration of muscle fibers and remodeling of the muscle? What is the connecting mechanism? As a broad answer to this question, loading provides the appropriate stresses to the muscle that stimulates adaptations to overcome that stress. These stresses imposed frequently and progressively stimulates adaptations in muscle to be stronger against the load being imposed on it. These adaptations are conducive to rebuilding and reconstructing muscle fibers and thus the muscle tissue. This again applies to just general resistance training and strength development, but also applies to rehabilitation as well. We are just providing a stress to the muscle to stimulate adaptation that eventually results in the remodeling of muscle tissue, growth of muscle tissue, and strengthening of the muscle. Now, the two major stresses that are imposed on muscle in response to loading are indicated here on this figure. There is mechanical stress and metabolic stress, with the former being more substantiated than the latter. Mechanical stress relates to the tension within the muscle and muscle fibers that directly correlates to the load being placed on the muscle. So for example, as you contract against a resistance, i.e. loading the muscle, there is an increase in tension that is formed by the contracting muscle fibers. This tension, especially when it is unaccustomed tension, meaning the muscle is not used to it, this will provide stress in the form of mechanical stress. Metabolic stress relates to the energetics of muscle loading. When the muscle contracts against a resistance, again, i.e. loading, there is an increase in the energetic demands of the muscle, also referred to as metabolic demands. In simpler terms, there is an increase in fuel utilization and energy transfer in the form of an energy molecule called ATP to power the process of contraction for each activated muscle fiber. As the energy demand increases, the metabolic stress increases. Like I said, the metabolic stress associated with loading and how that connects to muscle adaptations like growth and strength development remains vaguely understood, but we will circle back to this later on. For now, I want to focus on the more substantiated mechanism connecting loading and muscle adaptations that result in the remodeling or redevelopment of damaged muscle. So let's focus for now on mechanical stress, because this seems to be the main driver of muscle rehabilitation through loading. So now that we have a general understanding of what mechanical stress is, the next question is, how does mechanical stress connect to muscle regeneration and remodeling? How does it help rebuild the injured muscle? The two primary pathways through which mechanical stress promotes muscle anabolism, regeneration, hypertrophy, and remodeling include mechanotransduction and so-called anabolic hormones and growth factors. Mechanotransduction is the process by which a mechanical signal, like from the tension produced through loading, is converted to a biochemical signal like those needed to stimulate anabolic metabolism, like myofibrillar protein synthesis, as well as satellite cell activation, which is essential for myofiber regeneration. So this alludes to the fact that muscle cells have sensors that detect tension/mechanical stress and turn that into a biochemical signal for protein synthesis as well as regeneration. In the next couple slides, we will discuss this in some more detail. Another factor that is associated with mechanical stress via loading involves signaling from hormones and growth factors. These hormones include those that have shown to exert positive effects on myofibrillar protein synthesis and satellite cell activation, and are dubbed as anabolic hormones. The two primary ones implicated in this process include testosterone and growth hormone, which are released primarily by gonadal cells and the liver, respectively. However, it remains poorly understood based on the scientific literature on how loading and mechanical stress stimulates the release of these hormones and whether they play a significant role in growth and regeneration of muscle. All we know is that when there is supraphysiological levels of these hormones, like with administration of synthetic analogs of these hormones through drug applications, there is a significant growth and regeneration response. This is one reason many athletes resort to these controversial approaches to speed up recovery from an injury. Nevertheless, there seems to be some evidence to suggest that mechanical stress to the muscle via loading elicits an acute increase in these anabolic hormones. As for growth factors, we know up to this point as a normal process of regenerative healing, growth factors are released to help stimulate the process. Growth factors are known to stimulate protein synthesis in muscle as well as satellite cell activation, which again is critical for regeneration. These growth factors namely include insulin-like growth factor 1 or IGF-1 and a muscle-derived IGF-1 variant called mechano growth factor or MGF. Now, the connection between mechanical stress to the muscle and the release of MGF has been much more substantiated than the connection between mechanical stress and the release of anabolic hormones. MGF has also been heavily examined in its role in myofibrillar protein synthesis and regeneration in response to loading. The reason why this IGF-1 variant is called mechano growth factor is because it is released by muscle cells undergoing mechanical stress, and thus MGF interacts with the same type of cell that it is released from. This is referred to as autocrine signaling. MGF appears to be an important regulator of satellite cell activation and the process by which satellite cells regenerate muscle fibers or damaged fiber segments. MGF has also been implicated in stimulating myofibrillar protein synthesis, which again is not only important for hypertrophy of muscle fibers, but also the growth of regenerating fiber segments. The pathway through which MGF stimulates protein synthesis is commonly referred to as the Akt Mtor Pathway. Now, I won't spend time discussing this pathway in detail. However, if you would like to visualize this pathway, a quick internet search would do the trick. In my Advanced Exercise Physiology course, we will discuss this pathway in much more detail. So as you can see by this figure, mechanical stress works through mechanotransduction and anabolic hormones and growth factors like MGF to stimulate myofibrillar protein synthesis and thus the reconstruction of contractile elements within muscle fibers, as well as satellite cell activation to regenerate the damaged fiber segments. This altogether will eventually lead to the remodeling of the muscle back to its pre-injury state, at least to its best of its ability. It is clear based on the evidence available that mechanotransduction is the primary mechanism that connects mechanical stress via loading to adaptations within the muscle to the loading. This is in both resistance training and rehabilitation situations. Your muscle cells detect mechanical stress and convert it into signals that stimulate anabolism and regeneration. So what are these specialized sensors on muscle that detect mechanical stress during loading? These are collectively referred to as mechanosensors, and they are largely embedded on the surface membrane of the muscle cell. They are usually transmembrane protein complexes that connect the inside of the muscle cell to the exterior extracellular matrix. On the left here is one that we discussed in our first lecture series, the dystrophin-associated glycoprotein complex. This is the transmembrane protein complex that allows for lateral force transmission between the fiber and the ECM, but they also act as mechanosensors. Other known mechanosensors in the muscles include adhesion G protein coupled receptors, growth factor receptors, and integrins. These mechanosensors are essentially force or tension sensing receptor protein complexes. When the muscle contracts, especially against a resistance, i.e. loading, these mechanosensors detect force transmissions across the muscle fiber longitudinally and laterally between the muscle fiber and the ECM. During high tension contractions, like during resistance training or resisted therapies, these mechanosensors undergo conformational changes, which means they undergo some physical change. This conformational change in the mechanoreceptors causes subsequent stimulation of biochemical signaling that leads to processes like myofibrillar protein synthesis and satellite cell activation. Also, conformational changes like with the growth factor receptors causes increased affinity or attraction for ligands, which are molecules that bind to receptors. The ligand, of course, for growth factor receptors are growth factors, such as MGF and IGF-1. Thus, loading and thus mechanical stress can increase the affinity between these growth factors and its receptors, facilitating the subsequent signaling that is responsible for the stimulation of myofibrillar protein synthesis and satellite cell activation/regenerative processes. And as I mentioned, this entire process from loading to mechanical stress, to activation of mechanosensors, to stimulation of biochemical signals, to protein synthesis and regenerative processes is referred to as mechanotransduction. And this is one of the primary mechanisms that explain why exercise therapies and thus loading is most conducive to regenerative healing and thus functional recovery. As I mentioned, mechanotransduction and growth factors like MGF and IGF-1 have been implicated largely in regenerative processes, starting with satellite cell activation, which again are muscle stem cells that reside between the sarcolemma and the basal lamina of each muscle fiber, so on the exterior of the muscle fibers. Exercise, more specifically resistance exercise, has shown to be a potent stimulus for satellite cell activation via mechanotransduction and growth factor signaling. Now, keep in mind, following a muscle strain and therefore muscle damage, satellite cell activation will increase as just a normal process leading up to repair. But providing additional stimulus through mechanical stress may aid in that process and thus optimize the rate of repair of the muscle. On the top figure, you will see the general process by which satellite cells not only contribute to regeneration of fibers, but also the hypertrophy of fibers. You will also see all the positive and negative regulators of satellite cell activity. Let's go ahead and go through this process, which you may remember was introduced in our first lecture series. On the left, you have a muscle fiber. And on the muscle fiber's membrane, you have a pool of satellite cells. This is represented by the orange circles. The blue circles represent the muscle fiber's nuclei, which will be important in a topic coming up shortly. Now, upon activation, whether through mechanotransduction or growth factor signaling, the satellite cells, which are normally dormant or quiescent, will proliferate or multiply, as you see here represented in the color green. Some of the now proliferated satellite cells may return back to the quiescent pool of satellite cells on the muscle fibers, while others undergo differentiation. Differentiation I define in Lecture 1 as a conversion of a cell like a satellite cell to a more specialized cell with distinct functions. These differentiated satellite cells are called myoblasts. Now, the differentiated satellite cells or myoblasts have two paths from here. One contributes to regeneration and the other contributes to hypertrophy. During an injury situation like a muscle strain, The differentiated satellite cells, or myoblasts, will favor this route as highlighted by my cursor. They will fuse together and further differentiate into premature muscle fibers called myotubes. And like we discussed in Lecture 1, these myotubes will fuse to the surviving fiber stumps inside the regeneration zone and essentially grow into mature muscle fiber segments as they grow to close up that wound gap. This process involves anabolism and thus the construction of all the elements within the muscle fiber, such as those myofibrillar proteins. And as I emphasize, loading will help facilitate that process of protein synthesis as well. Now, in non-injury situations, these myoblasts favor this route here highlighted by my cursor. Although this route can also occur during injury situations as well, especially during rehabilitation. Myoblasts, instead of forming into myotubes, will simply fuse to the muscle fiber and become one with the muscle fiber. Through that process, each of the myoblasts will donate its nucleus to the muscle fiber. You can see now on this muscle fiber there are more blue dots representing the myonuclei. So what does this do for the muscle fiber? As the muscle fiber gains additional nuclei through this process, the capacity by which the muscle fiber can grow or hypertrophy increases. You see, the number of nuclei within a muscle fiber is one of the most critical factors determining the limit for that muscle fiber's hypertrophy. In simple terms, the more nuclei, the greater potential for hypertrophy for the muscle fiber. So as for a practical example, as you engage in resistance training, the mechanical stress stimulates protein synthesis and thus hypertrophy of muscle fibers. However, the muscle fibers can only expand so much until more myonuclei must be added to support further hypertrophy. So resistance training will also stimulate satellite cells, which through this process would increase the number of myonuclei to allow for further hypertrophy to occur. This is all explained by the myonuclear domain theory, which will be a topic in your advanced exercise physiology course. So please be sure to understand the different routes as I explain, and please be sure to understand that this route here is related to regeneration, while the route here is related to hypertrophy, both of which are important for overall rehabilitation for the muscle. Now, as a side note, as shown in the bottom figure here, this entire process undergoes a natural decline as a result of aging. It is common knowledge that with aging, recovery becomes more difficult and muscle growth becomes more difficult. One of the reasons why is because of the age-related declines in the satellite cell pathway that we just discussed. First, there is an increase in negative regulators of satellite cell activation, one being myostatin, as represented by this MSTN abbreviation, and the other being chemicals associated with chronic inflammation like interleukin 6 or IL-6. So satellite cells have a reduced activation response to mechanical stress or damage/injury. So in other words, satellite cell activity is reduced following an injury or damage, and satellite cell activity is reduced in response to loading, like during training or rehabilitation. As you can see represented by this jagged arrow here, the duration for satellite cell proliferation becomes longer or delayed with aging. This creates a delayed response to injury or mechanical stress during rehab. We can also see that there is an increase in negative regulators like myostatin specifically, which would impair the formation of myotubes in the regenerative pathway and impairs the fusion of myoblasts to the muscle fiber, reducing the amount of myonuclei, resulting in reduced hypertrophic capacity for muscle fibers. So delayed or impaired regeneration and thus healing, as well as reduced capacity for hypertrophy, is what is occurring with aging. This is one explanation as to why aging athletes experience delayed recovery from injury, longer rehabilitation from injury, and reduced capacity for muscle growth. This over time will result in declining muscle function, which is a hallmark characteristic of the aging athlete.